My name is John Lee. I run the U.S. subsidiary of Abion, and I'm not smart enough to go to MIT or Harvard, so this is really my first time in Boston. So it's great to be here on a business level. So thank you very much. So let me not waste any time and introduce our company and our founder, Dr. Shin. Obviously, you guys know about our ABN 401. Today, we are here to show you the efficacy data, and hopefully it's insightful and helps your research going forward. And we have members that are deeply involved in that research here today. So, ask questions later, and we'll go over the presentation, and we'll also have a forum. So thank you very much. And we have refreshments in the back, and, enjoy yourself. And any questions, ask our founder, Dr. Shin. Thank you.
Good afternoon. It's with great pleasure that I stand before you today, representing Abion, as we embark on our journey of discovery and innovation. First and foremost, let me extend my warmest greetings and heartfelt gratitude to each and every one of you for gracing us with your presence at this momentous occasion. As many of you are aware, Abion's mission has always been clear: to make a meaningful impact on the lives of the patient and their families. It's a mission that resonates deeply within us and serves as our guiding star. Our journey with ABN 401, our non-small cell lung cancer MET asset, has been nothing short of remarkable. It represents a testament to our collective vision, innovation, and persistence. Today, we proudly stand on the cusp of a groundbreaking moment as we unveil the phase 2 efficacy data for ABN 401. In the spirit of gratitude and collaboration, let us use this gathering as an opportunity to engage, exchange ideas, and foster relationships that will shape the future of medicine. Thank you once again for being here. We are excited to embark on this journey with you and looking forward to the discussions and discoveries that lie ahead. With that, let us begin this exciting event. Thank you.
Thank you, Dr. Shin. As we go in more deep into ABN 401, I'd like to introduce Dr. Lee, Se-Hoon Lee. I know there's a lot of Lees out here, so I'm going to do the first name as well. He's going to be the main presenter today with the slides in the back. What I can tell you about him is he's been in the ground floor of this research and has an MD, PhD at a Seoul National University. But what's important is he's been with the main research for non-small cell lung cancer involving EGFR and TKI. So let me give you the floor, and thank you.
I visited in Boston and researched for 1.5 years under Dr. Matt Myerson because EGFR, actually he was EGFR discoverer, yeah, but I studied at that time cancer genomics, yeah, very fortunately, yeah, so I'm very focused on precision medicine afterward, yeah, so I'm very happy to talk about MET skipping, actually MET inhibitor in Boston. So it's just my statement. So ABN401 has of course a MET inhibitor. So as we know, actually MET is a very important molecule. Actually, we know the EGFR, KRAS, and actually MET is a very well-known molecule to promote cancer progression and proliferation of cell and metastasis, of course. So, but it is very notorious to target because it is a very difficult target. Yeah, but recently we are succeeding on MET inhibitor for example, MET exportin skipping driver. Actually, MET exportin skipping is a very good druggable mutant in non-small cell lung cancer, such as EGFR mutation or REF fusion or ROS1 fusion, ARC fusion. So ABN401 is a highly selective and potent MET kinase inhibitor, very specifically targeting only c-MET. So in vitro study, ABN401 showed a very effective inhibition of MET signaling by binding its intracellular catalytic domain, which is very similar to usual receptor kinase inhibitor. So I will show the result of from the phase 1 study and phase 2 study. Actually, for safety data, I am presenting the data from the phase 1, 800 milligram of actually recommended phase 2 dosage, and phase 2 study for focused on MET exportin skipping. So for efficacy data, I will focus on 800 milligram of ABN401 against to both MET exportin skipping mutation. So it is just a phase 1 study, summary of the phase 1 study. Escalation study, so actually 800 milligram dosage was administered in 3 patients. And extension phase, actually 8 patients, more 8 patients was enrolled during the extension study phase for 400 milligram QD. So we have some responder during the extension stage. So actually, among the 4 patients with MET exportin skipping, 2 patients showed a partial remission. Based on this promising, actually it's a background of the opening of the phase 2 study. So during the phase 2 study, we enrolled the patient non-small cell lung cancer with MET exportin skipping and by tissue DNA or RNA NGS and RNA ddPCR. And of course, all patients, no previous MET-driven treatment. So we administered 400 milligram of oral daily. So primary endpoint was objective response rate, of course. A secondary endpoint, the duration of response, disease control rate, progression-free survival, overall survival, and safety data. Then we just completed stage 1, actually 15 patients. So actually, we analyzed this data after enrollment of the 13 from the phase 2 study. I am presenting the result of the ABN401 efficacy and safety data. Actually, some phase 1 study patient and 13 phase 2 study patient. So again, total patient is for safety analysis, 24. 24 is the patient treated with ABN401 for 800 milligram, and then they have MET dysregulation. For example, MET exportin skipping, MET amplification, or MET overexpression. So for efficacy analysis, we just included MET exportin skipping patient, or 17 patients, and these patients also treated with 800 milligram of ABN401. So median age and sex and race. Actually, race has enriched in Asian country because this study was performed in Korea, Taiwan, and USA. So actually, some enriched Asian country. So and smoking history has 1/3 and 40% of the never smoker and 60% of the smoker patient. Then actually some treatment naive patient included. Actually, this treatment naive means the patient did not get any treatment for advanced stage non-small cell lung cancer, of course, including a MET inhibitor. So it is a very important slide for actually primary endpoint. Response to ABM401 by site investigator. Actually, PR showed among the 17 patients, 58% of patients responded to ABM401, 800 milligram, if a patient had best efficacy skipping. Actually, again, reminder, so we set this analysis for the patient with bad exon skipping patient only, no other bad amplification or no overexpression. So if we focus on just previous treatment naive patient, so 75, yeah, of course the number is not big, yes, but 6 patients among 8 patients had treatment naive patient had responded to this ABM401 400 milligram, and it shows a duration of response, and many patients are still ongoing the treatment. So, for example, the first patient, treatment naive patient, still ongoing treatment more than 1 year and 2 months. Yeah, so now actually follow-up duration is not quite long. So some patients are still ongoing the treatment with ABM401 800 milligram. So again, treatment naive patient, objective response rate is 75%, and all best exon skipping patient, of course, all best exon skipping mutation patient had not treated with MET inhibitor previously. So response rate was 53% of response rate. So again, we are showing the duration of response and depth of the response with a spider plot. It is again among the 17 patients. Actually, 9 patients responded more than 50%, and treatment naive patient among 8 patients, 3 patients responded to ABM401, 75% of response rate again. It is a very representative image from the patient with skipping. Actually, the patient was treatment naive, and he treated tumor regression, actually measured 72 millimeter to 49 millimeter. Actually, just in 3 weeks, 32% of tumor reduction. So from the ABM401. So actually, finally, more than 40% of tumor reduction, and of course, partial remission confirmed in this patient without any treatment-related adverse event. So actually, MET inhibition has a big issue of safety concern. So different from the EGFR, ARC, ROS1, actually MET inhibitor has a more unfavorable safety profile during the cametinib or tefotinib development. So we are focused on safety outcome in patients with 800 milligram regimen. Again, actually, we are focused on each phase 2 study. So I will show the safety data from the phase 2 study, 13 patients, and again, 24 patients, phase 1 and phase 2 combined cohort. So from the phase 2 cohort, nausea, diarrhea, rash was the most common treatment emergent adverse event in phase 2 during the phase 2 study. So usually most of the adverse event is categorized within grade 1 or 2, and just one patient had grade 3 skin rash from the ABN 401 800 milligram. And to see the large number of the data of the adverse event, we are also showing the 24 patients from combined phase 1 and phase 2 ABN 401 800 milligram. So this table is a treatment-related adverse event, TRAE, in 800 milligram patient. Of course, the patient number is 24. And again, most common treatment-related adverse event was nausea, vomiting, and diarrhea. Yeah, but actually, all of this adverse event is grade 1 or 2. And one of the most concern is the peripheral edema, actually from the CRESS effect. So peripheral edema was observed in just 20% grade 1 and 2, and there was no grade 3 or greater event in all safety evaluable population. So actually, it is the some promising data based on the safety profile. Yeah, of course, our study is not quite too long to assess safety efficacy completely. Yeah, but it is a good signal for the safety profile for ABN 401 800 milligram. Yeah, and actually, again, treatment-related adverse event leading to permanent discontinuation of the drug occurred just 0% now. Yeah, of course, yeah, this data should be followed a longer time. So it is actually very comparative analysis of similar TKI, already approved cametinib and tepotinib. Yeah, so again, I should stress the number is quite lower than cametinib and tepotinib. Yeah, but actually, due to emergent adverse event and grade 3 or higher has 67% and 55% cametinib and tepotinib, and ABN 401 800 milligram at 21%. And again, treatment-related adverse event, grade 3 or higher, compared to cametinib and tepotinib, 38% and 28%, just 8% of patients showed grade 3 or higher treatment-related adverse event. So it will be the a good signal for the safety profile of ABN 401. So actually, take a message. The ABN 401 has a promising anti-tumor efficacy and favorable toxicity in locally advanced and metastatic exposure skipping non-small cell lung cancer patient. And actually, 58% of response rate with the exposure skipping mutation. So, and actually, if the treatment is done in treatment-naive setting, yeah, 75% response rate demonstrated. Yeah, of course, we always stress the small number of this study. So, and now, actually, median duration of treatment is just 5 months. It is the actually shorter and of course, longer follow is needed to confirm the favorable toxicity profile of ABN 401. And 24 patients evaluated for safety of 800 milligram. Yes, no decontamination occurred due to grade 3 treatment-related adverse event. It should be, again, could be stressed. And no patient experienced grade 3 edema. Actually, a very tedious problem of the MET inhibition this population. So now, still ongoing phase 2 multicenter open-label trial is actively enrolling in U.S., South Korea, and Taiwan. So actually, I'm there to say, as given its efficacy and safety performance, ABN 401 exhibit significant potential in in the ultimate goal is MET inhibitor should be combined with other drug because MET acquired resistance. MET is a very important acquired resistance mechanism, including EGFR, ARC, ROS1, and MET. Yeah, actually, every category of the oncology addicted non-small cell lung cancer, MET is the common pathway of the resistance mechanism to tyrosine kinase inhibitor. So it will be a very important message from, although we have a small number of data. Thank you.
Thank you, Dr. Seon-Lee. It certainly seems like you've done extensive research on the topic. So thank you very much. That's a good human advancement in my view. Next, we have a forum. And I'd like to introduce Dr. Park. He is, I would say, a legend in oncology.
Thanks, John, for such a generous and nice introduction and a warm welcome. Anyway, it's a very great pleasure and honor for me to have all the global experts of at least in this arena of c-MET or exon 14 skipping or dysregulated subset of patients of non-small cell lung cancer. Actually, we have really global represented here, right? Europe, United States, and Asia, right here on this podium. It's what a great honor for me to preside this wonderful showcase symposium. Let me first briefly introduce myself. Right now, I'm at MD Anderson, thoracic head and neck medical oncology. But I was originally from Korea. As John mentioned, originally from Korea. I used to work for the Samsung Medical Center. I'm also one of the lung cancer guys. I used to work quite hard, but now I'm relaxed and kind of enjoying some relaxing time here in the United States with one of my colleagues, Dr. Lee, Xiuning Lee, who's on the podium with us today. Well, let me first briefly introduce all of our distinguished global experts who joined us here on this podium. So first, right next to me, Dr. Jürgen Wolf, who you may all know, just for brief introduction, is a professor from University Hospital Cologne or Cologne, which is right from Cologne, Germany. And then next to Dr. Wolf, Dr. Liu, Dr. Xiuning Liu, who's working with me at Houston, MD Anderson, thoracic and medical oncology. And next to Dr. Lee is Dr. Lee, not Dr. Liu, Dr. Lee from Assam Medical Center. He's also one of the key opinion leaders of Korean Thoracic Oncology Society. And next to Dr. Lee is another Dr. Lee. He's also from Korea. He's working at the Samsung Medical Center, another key opinion leader of Korean thoracic medical oncology. So again, four of us, please, here at this moment, please welcome all of our global experts with a big applause. I wonder whether many of you might be quite, familiar with this kind of precision oncology, especially MET or exon 14 dysregulated, lung cancer patients and the resistant management. But anyway, as you just heard, ABION 401 is not the first in the class, but as you know, we already have 2 approved, clinically available drugs out there. Actually, including crizotinib, maybe 3, but most preferred choices in the management exon 14 skipping mutation at the moment by the current guideline is tepotinib and capmatinib, as you just heard from Dr. Lee's presentation, right? So you might be, some of you may be quite familiar with that, but compared with that, we are kind of latecomer, so I don't argue this is the first or the best one, but it's a very small and quite short follow-up period time. But as you just noticed from Dr. Lee's presentation, it's quite promising. I may say it's quite promising. It's quite promising in terms of efficacy and in terms of tolerability. Toxicity profiles. So with that, I'd like to invite all the participants from the audience to have, if you have any questions or comments, let me first start from the floor. So, any questions, comments from the floor?
Obviously, capmatinib, tepotinib approved in the US. You see with ABM 401, you've got the best response profile. ORR is high for treatment-naive patients. For the phase 2, will you still be able to recruit treatment-naive patients or patients who have not been exposed to a prior MET inhibitor?
So, do you want to take that question?
So currently U.S. patients do have options. However, the options, as you pointed out, response rate, even in the frontline CAP, Dr. Wolf reported 68. Tepotinib, I think I reported 50%. And then this ABM drug really is in par or potentially superior. As a treating physician, I feel comfortable offering as a frontline treatment in the United States. Furthermore, we all have been using MET inhibitors for a couple of years now, and we know the peripheral edema, the dense edema, is a challenge. Of course, GI toxicities for the existing approved 2 agents. This one also have the opportunity to make the patient, to make the quality of the life patient a little better. So from the physician perspective, I think both efficacy as well as side effects will put me very comfortable offering in the front line.
Thank you, Dr. Lee.
Yeah. Any other questions, comments from floor? Yeah, please.
Hi, I was very interested in your presentation, I guess. How was the condition of grade 3 treatment-related adverse event patient in page 2? Is there any dosage change?
So there was one case of grade 3, right? Can you give us more detailed information of that case? Who's going to give that case? Yeah, Dr. Lee. Yeah.
Actually, only one patient had a grade 3, yes, during the phase 2 study, and another one patient grade 3 was during the phase 1. Yeah, and fortunately, phase 2 study patient is my patient. So after suffering from the grade 3 toxicity, I reduced the dosage, actually 80 milligram to 600 milligram. Yeah, but due to the short duration of the follow-up, I'm not sure. Yeah, so 600 milligram was sufficient to maintain the response. Yeah, but as I commented, we followed actually the duration of median is around 5 to 6 months. So we should check the status of patient. Thank you for your good question.
Thank you.
I'd like to give additional comment regarding the rash. Actually, when using EGFR TKI, skin rash is a very unique but common toxicity. These toxicities relate to those of the EGFR TKI. But in this trial, we did not see the skin rash as frequent as EGFR TKI. So these rashes really relate to the drug mechanism or activity. I'm not sure whether these rashes really relate to the drug activity. So actually, I have already given these drugs to many patients of mine, but all of them did not complain of skin rash at all. So it's a rather unexpected toxicity rather than the on-target or off-target toxicity.
Thank you for your kind explanation.
So, Dr. Wolf, could you comment what's your first impression of the data presented?
Yeah, thank you for the question, and also thank you for the invitation, and congratulations to Evian for presenting these results. Yeah, first impression, of course, this is an effective drug. Clearly, overall response rate 75% in the first-line situation. But of course, the competitors, capmatinib and tepotinib, are also effective drugs. Otherwise, they would not have been approved. But what I, from the perspective of an oncologist who has treated really many patients with capmatinib as well as with tepotinib, is really remarkable, is the toxicity profile. So the low percentage of edema, for me, was the most impressive first signal. Because remember, this patient population is not an average trial population. So they are on average 10 years older with more comorbidities. And edema is a relevant clinical problem because there is no effective treatment of edema. So edema is really, so we use mild diuretic therapy, which we do not like in older patients. So we recommend exercising and compression stockings, but everything is unsatisfying. And edema is really an issue decreasing the quality of life of the patient. So I think it's interesting in first-line treatment for this special patient population, but of course, as already mentioned, as a combination partner in the resistant setting.
Okay, good. So you just heard, just for your information, Dr. Wolf is the global PI of the capmatinib study. He's actually one of the world best expert, at least with capmatinib. So he just mentioned one of the positive profiles of this 401, which is in sharp contrast to the currently existing approved drug, capmatinib. It seems to be quite, a remarkable difference, I can say. So Dr. Lee, who is another global expert of c-Met inhibitor, especially, tepotinib vision study. She's the senior author of that New England Journal of Medicine publication, as you may know. So now, coming back to Dr. Liu. So what's your comment on this initial data presented?
Yeah, I share the enthusiasm with Dr. Wolf and the rest of the panel. I think the drug is very promising, not only offering good potential efficacy, but also mitigate the high toxicity we've seen with existing approved agents. So I'm very happy to offer those as an opportunity for my patients in the front line.
So, Dr. Lee, I know that both of the drug capmatinib and tepotinib are available in the US, right? So you might have some sort of good experience with either of the drugs. So can you just share some of your experience in the clinic with either of the drugs?
Yeah, so we use both. I think because capmatinib was FDA approved earlier, so in the US, the majority of the physician actually prescribe capmatinib up front. It's a twice-a-day drug. Sometimes my older patient, they start to forget. So this IBM 401 as a daily drug definitely has also convenience to the patients as well. Tepotinib is a daily drug. However, those two drugs, both of them, like Dr. Wolf and other folks were talking about, when we first start the patient, we warn them about the potential edema. We are checking with them about their exercise, about their compression stockings. Nonetheless, oftentimes 4 to 6 months into the treatment, we start to see that very dense edema interfering with patients' life. They can't button, they can't write. There are times we start to see pleural effusion and pericardial effusion. Those could be life-threatening complications as well. So in the US, we use those drugs because they reduce the tumor burden, they have nice response. However, we are looking for opportunities. Can we improve upon? Can we at least make the patient on the right dose for even longer time? If that's the case, the patient probably can benefit even longer. So we're looking for new opportunities for all the patients.
Cool. Okay, so my understanding in Korea, either both of drugs, capmatinib and tepotinib, is approved, right? But not reimbursed yet.
Yes,
is that right?
both drugs are already approved in Korea, but because of financial toxicity, the Korean government cannot give any reimbursement.
So it is approved. Either of them is approved, right?
Yes.
So you may have some quite limited experience with either of the capmatinib or tepotinib, but if you have, can you share some of your experience with either of the drug? If you have.
Yes, I have. Actually, I have already participated in these phase 1 and 2 study of these capmatinib and tepotinib. Actually, Dr. Wolf already mentioned that the capmatinib has with a poor safety profile, actually, as well as peripheral edema. These two experts already mentioned or point out the peripheral edema, but I think when receiving capmatinib, many patients complain of general weakness, nausea and vomiting, and decreased performance status or quality of life. Actually, compared to capmatinib, tepotinib, I think with a safer safety profile, but still tepotinib has also some toxicity, although the toxicity of tepotinib is better than that of capmatinib. So we need more safe, actually, we need a safer drug in terms of safety profile or quality of life. In this regard, this avian compound might be a promising agent. Actually, in terms of efficacy, I don't think there are big difference between these three drugs, capmatinib, tepotinib, and the avian compound. But I think when giving the tyrosine kinase inhibitor or target agent, we consider the safety profile as well as efficacy profile, because many patients receive long treatment of EGFR TKI. So actually this situation is similar to EGFR TKI. In terms of EGFR TKI, osimertinib is a better safety profile compared to other EGFR TKIs, first generation or second generation. So we prefer, especially in Asia, actually, osimertinib did not improve the overall survival compared to first generation or second generation EGFR TKI. But in Korea, many doctors prefer the osimertinib because of good or better safety profile. So we need an agent having a safer and better safety profile.
Okay, good. So, Dr. Lee, so another Dr. Lee, another doctor, please. Can you share your own experience if you have?
Yeah, actually, Dr. Wolf and Dr. Lee and another Dr. Lee commented very well. Yeah, and actually, they have a big experience. Probably I should just echo their voices. Yeah, so actually, when we treat actionable driver mutation patient, we always expecting, for example, longer follow-up duration. For example, sometimes we prescribe 3 months medication, osimertinib or alectinib or lorlatinib. But probably if we have this safety profiling of peripheral edema from the MET inhibitor, capmatinib, tepotinib, probably we can prescribe a long duration of prescription because of the concern of the safety profile, and probably a patient should visit our patient clinic on scheduled visit. Actually, we are very concerned about the safety profile from the targeted therapy. Probably this will be a good opportunity to test a better safety profile. And again, we can stress the the combination of the MET inhibitor because always MET is one of the acquired return mechanism. Recently, I prescribe for ARC and MET. The patient prescribed with the crizatinib and lorlatinib. Actually, due to the crizatinib has some MET activity, so I should reduce the drug dosage. Yeah. So we have a better safety profile compared crizatinib, tepotinib, and cametinib. We are happy to combine drugs with the other targeted therapy.
One more comment. I would like to I'd like to point out the patient characteristics of patient c-MET skipping mutation. I think you already seen the patient characteristics. Actually, unlike other external mutation, more male patient might harbor the c-MET skipping mutation. And actually, compared to other external mutation, the median age of diagnosis of c-MET skipping mutation is rather older. More than 70 years, whether compared to other external mutation. Actually, in other external mutations, the median age of diagnosis is less than 60 years, which means that we need more safer drug. Actually, elderly patients sometimes cannot tolerate well even EGFR-TKI therapy. Actually, I think you know well the tyrosine kinase inhibitor is a better drugs in terms of safety profile, but external mutation, the patient harboring external mutation might be whether in good performance status, but c-MET skipping mutation positive patient might be different from patient harboring other types of external mutation.
Okay, good. Thank you. So if there is any other question, come, please do not hesitate. Okay, come on.
Hi, so yeah, John Travers again. Maybe two more questions. The first on co-mutation, in this case MET amplification. So many exon 14 patients also have co-amplification. There have been reports that from the geometry trial that potentially capmatinib doesn't work so well in patients who don't have co-amplification. I wonder if the panel could potentially comment on the veracity of that or real-world experience, and whether later generation MET inhibitors like ABM401 could potentially work better in that patient population.
Yeah, there are two aspects. So one is co-amplification in patients with a MET exon 14 skipping mutation. So we have looked in the trial data of the geometry trial for capmatinib, but there was no correlation. So it's not a better efficacy if in addition to the MET exon 14 skipping mutation is also MET amplification. So there's no correlations. This is the first thing. The second point is MET amplification as a true driver. What do you mean? Yeah, so the efficacy was lower, definitely. It was around 40% in the first line, around 30% in the second line, but only with a really high gene copy number level of 10 and more. And this is a frequency of only around 1%. So I personally think it's a medical need to develop targeted therapies against MET amplification as a driver, in particular in the situation of resistance or after primary IO chemotherapy. We have discussed it with both companies in the meantime, but there's not much interest. So it's used off-label. In Germany, at least in my country, we use it relatively often in the off-label situation if we do NGS testing in relapse after IO chemotherapy, and we see MET amplification, a significant MET amplifications, and we use a MET inhibitor, and we see responses, of course, and a higher response rate, of course, as a standard treatment of docetaxel.
Just want to add a couple of data points. We reported about 2 years ago a 700 patient cohort with MET MET exon 14, combining US Garden cohort and the GenPlus China cohort. In those cohorts, we saw about 8% MET exon 14 with co-amplification. So it's not a huge patient population. In the clinical experience, I felt those patients do tend to respond a little better. Almost feels like the tumor is a little more addicted because they not only have the skipping, but amplified that particular event. So the tumor is a little more addicted. But if that will really truly translate into the big difference, I don't think we have that power sample size to distinguish. So that's that one comment. In terms of MET amplification as a de novo event, I think Dr. Wolf's earlier publication delineated really well where when you have extremely high focal copy number change on chromosome 7, not having EGFR BRAF that's on the neighbor that's also amplified, those 10%, those 1% of the patients, they don't have KRAS co-mutation, they don't have other driver events. They are actually the driver with greater than 10 copy number when it's a focal. It's a smaller patient population. In the US, it's in the NCCN guideline. We actually can use it. So some of the physicians we do oftentimes as a second line option after those patients exposed to other systemic therapy.
So either capmatinib or tepotinib?
Yeah, so that's both, because I think you reported in the original New England Journal paper really nicely delineate less than 4, 4 to 6, 6 to 10, and greater than 10. And in the Vision trial, they have arm cohort B, and then those ctDNA copy number greater, actually similar to tissue greater than 10. We reported a year ago at ASCO, same response rate, 42%, better in the front line than the later line.
Cool. Yeah, good, great. So any other questions?
I do want to say that I agree that it's a unmet need because currently, although it's in the NCCN guideline, but a lot of people are not aware of the benefit. So I do think there is a space. 1% non-small cell lung cancer is basically half of the acute leukemia diagnosed every year. So it is a unmet need.
Yeah, good. So, yeah, interesting. Yeah, good. I now feel like that we will have global experts here that can answer every question you have. Okay, please do not hesitate to have a question. Please come out. Please. No. If not, I'm gonna move on discussion point to something else. Now, everybody mentions combination, right? So combination, I believe, yeah, maybe that's the next one to pursue. But I don't know whether the more the better or the less the better, right? So I think we're kind of dilemma here. So of course, we do know not any single target agent has ever cured of the advanced metastatic disease so far, right? Then maybe the same is true with this c-MET exon 14 skipping and or amplified subset of population as well. So now the next wave of research may be, of course, combination strategy, right? So what is your position? What is your personal, opinion on the combination in this subset of population? So who's going to start? Dr. Lee.
So it's actually exciting that we have drugs have a different mechanism of actions now, that combination become possible and feasible. I think like a couple of weeks ago, we heard about FLAURA2 combining chemo with TKI. I think we will be hearing antibody-based combination with TKI with chemo. I do feel excited about potential combination, and the TKI combination has always been there as well. So I do feel if we combine smartly, we probably can achieve better benefit for the patients.
Yeah, I totally agree. And in addition, I think we have, regarding this combination discussion, we have to distinguish two scenarios. So combination for the MEDEX and 14, as you have mentioned. And the only thing is, what we have to consider here is that this is a more fragile population. And if you see the toxicity data of FLAURA2, I would be a little bit skeptical for these older patients, at least if there is a pronounced comorbidity to use it together with a chemotherapy, because we are very happy now to have a MET inhibitor without these side effects. And to add one aspect to our previous discussion, seeing the trial data, I was also impressed that the permanent treatment discontinuation rate due to adverse effects is 0. So it was around 10% with tepotinib and around 10% with capmatinib, 10 to 15%. So here, as you mentioned, we need smart combinations. Maybe IO, but MEDEX and 14 is not immunogenic necessarily, so we have to think about. But what is definitely attractive is for the MET amplification as a resistance mechanisms in TKI therapy is a combination, and we have seen trials with the EGF receptor, TKI resistance, Savannah, Insight, and so on. It works. It's also my personal experience. I have treated a lot of patients with osimertinib and tepotinib and with capmatinib. So it has a relatively favorable toxicity profile besides already mentioned edema. So I think this is really a very an exciting perspective. Also because MET amplification is across all typical receptor tyrosine kinase is a widely spread resistance mechanism.
Well, our panels are, support of combination. Of course, I do think that's the next wave of research. But personally, I'm a kind of guy who prefers the less the better. That's my personal principle when treating my patients in the clinic. So even though I agree, the next wave of research will be combination, but is it really the best or the only approach? We may have some, split of opinions there. So now, that being said, can I ask you kind of silly or provocative questions? Please do not misunderstand. I'm not offending you. I'm just asking for discussion, okay? So given the small, very promising data, 75% of response rate in the treatment-naive population with ABN-409, do we still need combination in the first line? Then what's the goal? What's the goal? What's the goal of the combination to beat that 75% of objective response rate in the first line as mono? So if you would like to try combination in that setting, what's your goal? 90% response rate or what?
I think we need response rate and duration of treatment.
Yeah, of
Actually,
course.
when using ARC-TKI, we do not consider the combination at all, because when using ARC-TKI, the median progression-free survival is more than 4 or 5 years. In such case, we do not want the combination of ARC inhibitor and other agent. And in addition, actually, when using the combination therapy, we have to consider the toxicity. Actually, especially for EGFR TKI or other types of TKI, when combining other agents with TKI, we might see the unexpected, very serious toxicity, pneumonitis, hepatitis, or others. In such case, the patient might lose the opportunity from the single agent efficacy at all. So when consider the combination, we have to consider the toxicity. And in addition, we also consider the convenience. Actually, TKI is an oral agent. However, immune checkpoint inhibitors or the antibody conjugate and chemotherapy is an intravenous drug, which is very inconvenient. So when consider the combination, we have to consider both toxicity and convenience, as well as efficacy.
Okay, Dr. Lee, any defense?
I think about the other camp of like aggressively combine upfront. Because, for example, the recent report of FLORA-2 demonstrated statistically significant progression-free survival in the first line, even with an excellent drug like Tagrisso. And then osimertinib, their baseline, either combined or not, the response rate is 75 to 80%. And then our own data showed very similarly. Biologically speaking, there might be a subset of patients if you aggressively combine so that the initial tumor burden will be reduced so much that you might be avoiding certain resistant clones down the line. And then I think for me, I think it's basically style type of thing. I want to treat very aggressively upfront and then trying to derive as long as a benefit as possible.
Okay,
Yeah, normally means for the majority of the drivers in lung cancer, this is exactly also my philosophy. But as already mentioned, given the special characteristics of the MET exon 14 patients, is the older age, the higher comorbidity, I'm a little bit skeptical. So with tepotinib and capmatinib, we know now that the median overall survival in the first line setting is around 2 years. 2 years, a little bit more. And so I would expect at least also these 2 years. So means that we have this older fragile population with a very mild therapy. We have a substantial proportion of patients. They live longer than 2 years because it's a median. So, but definitely there is also a subset who might benefit. So maybe one could think, but this is more research than clinical practice.
Right.
Maybe one could think about a translational program looking for clearance with liquid biopsy to identify such a population which might benefit from a combination. But
yeah, here we hear that our experts say that we may expect some additional benefit, additional better outcome with the combination, but maybe at the cost of some increased toxicity, especially given the specific, peculiar characteristics of this population, who are typically quite the old population, median age 70 plus minus something, right? So compared with the other subset of driver oncogene-driven subset of lung cancer patients, they are maybe 10 plus minus years older as a median age, right? So that not putting aside, now that Dr. Le, you just mentioned about one of the potential combination partner could be ADC, right? So that now that you're saying that, may I ask you that, coming back to the another ongoing trial, so-called Mariposa, right? So which combines ADC, amivantamab, which is a bispecific EGFR MET bispecific antibody, right? If the Mariposa starts, it could be a positive trial, maybe statistically, but I don't know whether how relevant clinically anyway, right? So if that study, turns out to be positive later on when the final data is available, what's going to be the, fate of our c-MET inhibitors? Not just ABN-401, but including tepotinib and capmatinib. They'll still be there? You understand what I'm talking about, right?
So amivantamab, the EGFR MET bispecific antibody, I think we probably want to separate in the MET exon 14 space versus in the MET amplification resistance space. In the MET exon 14 space, I think there's still a huge need for TKI, especially upfront, a tolerated TKI. Older population, we need better tolerability. And then TKI offers really already excellent response if the patient can stand on the TKI long enough. For the resistance setting, I think it's a little bit different, where the Chrysalis 2, Dr. Benjamin Bassi showed that after EGFR TKI progression, this double approach could be quite efficacious in the MET high patient population. So that I think for the antibody-based approach, especially that particular agent, will be a very strong competitor against TKI-TKI combination.
Okay. Any other comments from our panelists?
I'd like to ask you, Professor Park. I think you have already participated.
I'm a moderator.
But however, you have already participated in the combination of CMET and EGFR TKI therapy. What is your opinion
No,
about
actually, I stepped down from the investigators. And Dr. Lee is investigating now the combination. But anyway, this is a really tough question. We don't have right straightforward answer here. But because we are running behind our schedule, so just to wrap up, really, enjoyed our discussion from our global experts here on the podium today, and hopefully that would help you understand what's going on in the subset in this arena of exon protein skipping plus minus. MET amplified subset of population, what's going on in terms of precision oncology approach. So there's another rising guy called ABON-401, which seems to be quite promising, especially in terms of better tolerability. So please keep that in mind when you're coming back home. And another question you have, please do not hesitate to come back to email or to to message, whatever available. Then we are happy to address your questions. And thank you very much, all our global panelists and all the attendees there. Thank you.